Welcome back to this special edition of The Dental Guys, here live from the AO 2024 in Charlotte. I'm John, the Dental Guy.
And I'm Wes, the Dental Guy.
And man, I mean, Wes, every time we come to this meeting, once again, we get to have some of the most brilliant minds in implant dentistry. We get to have our ideas challenged. And of course, we keep coming back to that this is a meeting about pushing beyond the boundaries of what's possible. But in order to do that, we have to know what works. We have to know what works. We have to understand where we've come from. We have to be, as we always say, standing on the shoulders of the giants from before. And I think that we've got a topic we want to really dive into today with somebody who's certainly we consider an authority in the bone grafting world, and that is Dr. Craig Misch. So welcome to the show.
Thank you. Thank you for coming on.
Yeah, glad to have you. And first off, let's start with kind of what's brand new, which is Quintessence just has kind of released a new book that you've been, and the title of the book is, I think it's a pretty bold title. The title is basically horizontal vertical bone augmentation.
Yeah.
Right? I mean, that's it.
Yeah, it's an encompassing text. I mean, let's face it, horizontal vertical bone augmentation, that's a big topic. So I try to look at it from an academic side as well as a clinical side. So some books I've seen are, this is how I do it, but I wanted to do a book that says this is why you do it and this is how you do it. So kind of give a scientific rationale, and then also try and make it an evidence-based decision tree that we make on, you're running against this clinical situation for a horizontal defect. I need to grow this much bone. What alternatives do I have?
Yeah.
So there's a lot of different ways to augment bone, which is good. I mean, today it's becoming more and more predictable what we're doing, and we've got more and more materials, techniques available to give us more consistent, predictable results. Also, there's something I call the graftless approach, which today we can use narrow implants, shorter implants. So what that does is it lowers the threshold of how much bone you actually need to augment and still have equivocal outcomes. So maybe that's going to make it give you an option to use minimally invasive approaches, maybe lowers complications, and still gives you good predictability. So
yeah. Now we saw back in 2021, I think it was, that you published in IJPRD a decision tree that it sounds like in some ways kind of gave way to developing that into a textbook that kind of took all of that decision tree, but then went to, as you said before the show, who's doing this the best. And then let's keep this all kind of consistent in how we approach it in each chapter of the book. And that's, as you said, not typically how it's done. Usually it's, well, this person's going to write this chapter, and that could be a slightly different approach. You have to kind of, it takes a lot more work, I would think, to take all of that information and then put that into a chapter that you kind of get to put your own little bit of a touch on. Yeah. So it took a long time to get there, I'd say.
Yeah, of course, when you work with multiple authors, everyone's busy, everyone's got a schedule. So what I tried to do is they would write something, then like I said, what my thought was, let's get a cohesive product that has a consistency to it. So I could take what they wrote, tweak it so that the message is consistent, that there's a theme throughout the book. And I'm happy with the product. I think all the co-authors that have seen it are happy with it. Quintessence is a fantastic publishing company. I mean, I consider them the top when it comes to tech. So that's who I wanted to partner with. And yeah, it took a while, but that was on my bucket list. I'm glad it's off.
Yeah. Well, let's dive into some of the details then about that, because, you know, as we look back at that, we haven't gotten a chance to read the book yet, but we have read through the decision tree. And, you know, when we look at what's possible, there's things that are possible, there's things that are predictable, that are not always the same. And then there's things that require a certain amount of clinical skill.
Right.
And I wonder if you could speak to, I think many times we hear people say, well, that person can do that.
Right.
But is that going to be generalizable to the typical clinician? How important is the clinical experience and expertise compared to the type of procedure, the biomaterial, the technique?
Yeah, you can't, I can't speak enough about experience, training, expertise. So the book, I don't talk about intraosseous or intrabony defects like socket, sinus, or let's say you have a defect in the ridge, because bone grows from surrounding bony walls. If you have a socket, sinus, or intrabony defect, you've got a very favorable site for bone regeneration. It's easier to obtain primary closure. You don't have pressure from the flap. It's easier to protect that graft during healing from a provisional prosthesis. So you've got a high degree of success with treating intrabony defects. And if you look at systematic reviews, studies on intrabony defects, the majority use bone substitutes in either a collagen dressing to keep the graft in place, for instance, a socket, or possibly a collagen membrane to contain the graft. So that decision tree isn't very complex because you're going to treat those cases more or less the same way.
Mm-hmm.
It's where it becomes more complex is, horizontal. And what I did with the decision tree is looking at not how much bone you have, it's how much bone do you need.
Mm-hmm.
So, and then look at low, medium, and high gains, and not only what techniques, but what materials are going to fulfill that. So if you're trying to get greater horizontal bone gains, you probably have a greater need to consider autogenous bone as a
percentage of
of
the
graft.
Yeah.
Right.
And then looking at different types of membranes, what I thought was interesting when I went into this project, I thought if you look at a larger horizontal gain, that I thought that if you use a resorbable membrane, that a cross-link membrane has a longer barrier function than a non-cross. Mm-hmm. So I thought that a cross-link membrane would give you better outcomes for larger gains, but the literature doesn't support that. And I wish Istvan was here because his sausage technique uses a non-cross-link membrane. And when I went back and looked at the data, that sausage technique is producing higher gains than cross-link membranes.
Which you wouldn't think would be the case.
Right. And I think what was happening is if you look at the way he does this technique, he tacks the non-cross-link membrane and it has a stretchable quality to it. Mm-hmm. And then he's packing this autogenous bovine bone mineral mixture and really packing it in and then stretching it and then tacking that. So you're getting very high stability of this graft complex. Mm-hmm. And if you go back to Hamle Wong's past principle, stability is one of the key principles.
Movement kills bone.
Yeah. So Istvan did a study with another group, and they compared conventional GBR with a cross-link membrane versus the sausage, and the sausage significantly grew more bone than a cross-link membrane.
It goes against everything we know in basic surgery is, we want type 1 collagen, right? And, you compare this to what, like you said, you have to sometimes kind of think a little differently.
Yeah.
And I want to, before we get into some of the questions we have about augmentation and really getting to augmentation, you mentioned something there. You really have to decide how much bone you need first.
Right.
Sometimes you don't need augmentation. In fact, you've said in the time that we've really spent listening to you over the years, you've said, before I graft, I consider short implants.
Sure.
I want you to talk about the adoption of short implants into your practice. What made you feel comfortable adopting that? Because we really still have a problem with adoption and of the short implants. And we're talking about implants that could push, less than 7 millimeters in height. I really feel like that, they've redefined what a short implant is because of some of the things that you've even done in your career.
I think there's just more evidence. In fact, Lyndon Cooper made an interesting comment. He said the problem that we have is we have more systematic reviews on short implants than we do studies. But this topic is, if you look at PubMed, short implants last 5 years, the number of publications has just gone up. So Andre Ravada from University of Pittsburgh, he runs the perio department there. He has a number of high-level publications on this particular topic. And one particular paper that I like that he wrote it's a very comprehensive review. And what he found was in the posterior mandible, short implants perform well. You go down to 4, 6, 8. Mm-hmm. You're not seeing an advantage maybe putting a 6 or an 8 in over a 6. However, what he found on the maxilla, there was a difference. For each millimeter, decreased the risk of having failure and improve the long-term outcome. So in my practice, the way I feel very comfortable using, and also not all short implants are the same. The other thing that I started to embrace a lot more is the tissue level design. So a tissue level implant, instead of having a long crown height, that tissue level component cuts into the crown height.
Yep.
And it gives you a more robust, wider platform for that. And then if I have a question, I can place 2, 3 short implants. If I'm getting crown height that's higher than 10 millimeters, then I may favor splinting those.
Yes.
But I don't routinely splint short implants. It's based on crown height. And people talk about crown implant ratio, but that's a terrible term because the implant length is irrelevant.
Exactly.
That's
Once
exactly
integration
right.
occurs, it doesn't matter.
can't offset a tall crown with long implant.
That's right. It doesn't work like that. Yeah.
I mean, it seems like people forget that some of the literature came out on, where forces are since the 90s. In 1994, I think there was a study released and it showed forces are inside the first 5 millimeters once these implants are integrated.
Yeah.
And so
you could just cut the bottom of that implant off and it would be the same. And that's where I think you have to think about more mechanical complications is the potential, right? Well, we're thinking about splinting.
For taller crowns.
Correct.
Yeah,
Correct.
exactly.
And that's where I think you said that it really implant design starts to matter more, and we've said this too, because really the biggest complications we run into is with mechanical failure with some of our short implants. And design really does matter. I mean, you go across the floor tonight or this evening, and there's really not a lot of people just excited about short implants because I truly believe, and I know John believes, this is the hardest implant to work with because everything matters.
Yeah.
Stability,
Yeah.
the osteotomy prep, it is not for the young clinician or the inexperienced clinician.
Yeah.
Talk a little bit about that and why all these things matter.
Well, I was talking with Andrea about the mode of failure of short. So what I see in clinical practice is it's not this progressive loss of bone around a short implant. That's not typically what I see. I would consider, if I saw that, I would think that's more of a peri-implantitis mode of failure versus an overload. But what I do see in some cases is when a short implant fails, it just loses integration.
Right.
And I think what happens if you go to Frost had what's called the mechanostat theory. And Frost looked at what happens when you overload an implant. You don't get bone loss, you get bone gain.
Right.
So they've done a number of studies where they measure the density of bone around short implants, and it's denser than standard length implants because you're overloading that bone, and it's Wolff's law that bone
apposition
responds to the load that's placed upon it. So if the shorter implant has maybe a greater load upon it, then the body remodels that bone and makes it more dense so it can handle that load. And then what happens in some patients, they, due to systemic or due to local factors, they may not have the physiologic capacity to keep up with that, and then the implant just loses integration. So,
It's again an immune response that we're talking about in this meeting right here. It's multifactorial.
Yeah.
Choose your patients wisely.
Yeah.
So we don't have enough bone.
Yeah.
And John, you and I have done with our surgeon a lot of cases where technology was maybe used or employed to maybe mill an allograft.
Yeah, because the thought process on a lot of this is, of course, as surgeons are looking at the potential challenges with vertical grafting, right? Because that's I think always been the big dog, right? Of people been concerned with, and there are obviously as you mentioned, a lot of expertise, a lot of training required. So they try to find a way to maybe reduce the morbidity of the procedure, right? So instead of going to iliac crest, instead of going to tibias, instead of going to calvarium, we're going to go, well, we can custom mill this allogenic block. And you mentioned in your decision tree that while these blocks in and of themselves don't really have the capacity, regenerative capacity, but potentially with growth factors. So to speak to that, because one of our surgeons, for instance, that's a good friend, has said, well, the problem with these blocks way back was they didn't adapt well. So if we could custom make them, if we could get them to adapt better, that would make a difference. How do you feel about the place for allograft blocks at this point?
Well, in general, if you look at the literature on allograft blocks, the majority of studies are on horizontal, not vertical augmentation. And also, if you look at histology that's been done on allogeneic blocks, they take a longer period of time to incorporate. There's a lot of necrotic bone. It doesn't turn over as fast. And the other variable is how much resorption that you get. There's a lot of variability with that as well. So maybe 5-6 years back, I started to use recombinant BMP2 with these allogeneic blocks, trying to increase the biologic, growth.
That's right.
And improve that. Instead of having it taking it longer, now I've got something to kind of rev it up.
Up signaling, yeah.
And I had the study that I did, 37 blocks. The average ridge width this was just for horizontal. Average ridge width was 1.6 millimeters with a little standard deviation, not too much. All the blocks incorporated. Placed 60 implants, 1 failure. So I was happy for horizontal augmentation of using it in that capacity. But for vertical augmentation, I wouldn't use an allogeneic block, even with a growth factor. There's too many other techniques that we have available. I look at Urban's work with titanium reinforced dense PTFE and using 50% autograft, 50% biomaterial, bovine bone mineral. And then, as he said in his lectures, if he's trying to go beyond, he had a study that was great. It showed up to 5 millimeters, he had 100% regeneration. If you went 5 to 8, it knocked it down a little bit. What percentage? And then you went over 8, it knocked it down to, I think, 12% less chance of getting the total amount of regeneration. But what he also said is, if he has those cases where he needs more height, he's changed the ratio. Instead of 50-50, maybe go 75 autograft, 25% bovine. Okay. And then he's got what he calls his lasagna technique, where he puts a BMP sponge over the top and uses a perforated PTFE membrane, trying to get the periosteum to contribute. Now, I've never thought the periosteum played a large role, but from his work in histology, it does seem to improve that superior part, because that's a long way for vessels and everything to grow from the native bone. So that seems to be a contributing factor. What I love about this field is you've got people that push the envelope. We get more materials, techniques available to us, and István's certainly been at the cutting edge of this. So following his lead, I see something he does, I take it back, and sure enough,
Let's come back to training for a bit. And experience. We've come out of dental school, went into oral surgery, or maybe even a perio program, and we're coming out. We're going to see a lot of these cases, and or start to see as we build a referral base, and we're coming to these meetings and we're seeing what's possible, and we're wanting to know more. Yeah. Where are we learning these things? Because I feel like that there is it's kind of like unknown in some ways. Yeah. And we want people to know where they can get quality training beyond just reading in the literature. I mean, we want them to buy your textbook, but it doesn't just stop there. It has to be, there has to be some type of experience. Yeah. Yeah.
Well, and what I find is the benefit of a residency. Not all residencies aren't the same. I mean, there are some oral max residencies that don't spend a lot of time looking at implants. There are some perio residencies that get more implant experience than others. But what I've said, what I find takes the learning curve and does this is hands-on with someone that's experienced, looking over your shoulder, telling you, make the incision here, reflect this, do that. If you got someone that's looking over your shoulder and telling you how to do something, trying to go to a weekend course and then go back to your office and do it, your learning curve is going to kind of just do this. You're going to kind of, and then what else changes the learning curve? It's the frequency that you do a procedure. And in a residency, if you're doing these, every day or, multiple times a week, again, that has a tendency to do this with the learning curve. So I would say that it's, the frequency that which you do something, and then you grow. I always like the SAC classification.
Yes.
Straightforward, advanced, complex. So you master the straightforward cases, and you're having good experience, and then you move on to the next level. And there's certainly procedures that, especially you start to look, horizontal augmentation, I think is a more predictable modality to incorporate than vertical augmentation. And maybe now you've mastered horizontal, now you want to start going on to the next step. So you just do it in a progression, if you will. I think that kind of makes the most sense in someone's evolution of how they're going to start incorporating.
Can we do a better job in dentistry in helping general dentists do the straightforward cases and identifying through these types of classifications that these are straightforward cases, and being able to identify that this is an opportunity for ridge augmentation? How are we embracing this idea that general dentists, it's not an idea anymore, they are placing dental implants?
Sure.
And we know that the success rate in the hands of a general dentist is lower than that of a trained oral surgeon or a trained periodontist. The literature shows us that. And I know they don't want failures, but how are we calibrating for? And I want to use endodontist as kind of a they really have done a pretty good job in their organization and coming up with consensus statements and saying, hey, we have this type of classification for what's hard, what you should look for.
Right.
And that led to really their profession kind of taking off.
Yeah.
How can we change going forward here as implants become more in our field?
Yeah, it's tough. What I tell a lot of general dentists is, I think extraction of a tooth, a socket graft, coming back later to place an implant, that's certainly straightforward. That's in your wheelhouse. And you do enough of those and you start to feel confident, then you might be ready to go on to the next level. But what gets a little bit tough in my practice is seeing complication cases where the clinician stepped beyond what they had knowledge or skill, and now you've got a complication. You've got a patient that you're never going to get the same success rate the second time or the third time that you do it. So that makes it a little tough. So I do think that there needs to be a better education on not where do you draw the line, but where do you need to at least be aware that you're starting to get into territory that's going to be more challenging.
Yeah.
And I've certainly seen cases where I look at the case and that would have been hard for me to do that case.
Yeah.
And this doctor tried it. So I don't want to throw people under the bus and say.
No, it's reality though. It's reality.
Yeah. It's just I feel bad for the patient. I feel bad for the doctor because the doctor certainly didn't go into this
wanting a failure.
No one. So it's a kind of a lose-lose situation. So you just got to try and help that patient and try and give them options on where can we move forward. And sometimes it's decreasing their level of expectation that we can't achieve the same result with a retreat. And maybe we change the plan. I've had some cases where we say, well, I know you want fixed, but you just don't have enough bone to be able to do that. Would you consider a removable option or a bar overdenture that's still going to make it very stable, but it's something. So start to look at other ways that we can fix these pain. And then what we're seeing today with peri-implantitis being, increase in frequency, we're seeing greater need for vertical augmentation. And also I think what needs to happen as well is we understand that maintenance of implants plays a large role on being able to maintain long-term peri-implant health. So you get some patients that get, things done, they don't go back, they don't have maintenance done, and then a problem comes up and now they're seeking treatment. So also my referral base, I try and educate as well as, I want a radiograph at least once a year. I do want you to probe that implant. Bite wings won't do it. You got to get a periapical of that implant. And if you start to see something early, let's jump on it. Because if we can catch it early, maybe we can keep that implant around. And I saw some great presentations this morning on peri-implantitis, things that I always love this meeting because I always learn something I'm going to take back with me on treating those types of cases. And I work in a city where it's a retirement community. So I'm working with people in their 60s, 70s, 80s, and I don't want to remove all their implants and start over. I've got to come up with techniques that I can maintain them and keep them going and functional.
Walk us through with the patient when we're looking at a case where we're thinking titanium reinforced PTFE and vertical augmentation. Walk us through with the patient how you set expectations for what they should expect, how you discuss things like success rates, and what should they, how long is this going to take? How difficult is this going to be? Because I think, we see the techniques, but, what's the reality of how we walk a patient through that discussion and maybe versus the short implant discussion, but because obviously you've seen enough of these cases to know what really happens. What are the typical complications? What are the success rates? Talk us through that a little bit.
Well, I think you have to have let's look at cases. So if you're looking at aesthetic zone cases, there I have a very long discussion with a patient on what we can do, what we can't do. There's going to be, you might not get interdental papilla that look like the natural teeth. Now, Bach Lee just lectured, and he was just talking about how patients' perception with vertical defects, they're more concerned about the length of the tooth than they are the papilla. So if you can even give them the illusion that there's a scallop, they probably are going to be satisfied with something like that. So aesthetic zone is something where I spend a lot of time. Also with digital dentistry, doing these digital wax-ups, you got to be careful because I've seen some labs create digital wax-ups that look like natural dentition.
Yeah, you can't even achieve that.
We're in that same place right now.
What you can do, though, is on some of these large vertical defects, especially if their lip line is not going to show the transition zone, we've got some wonderful laboratories that can get prosthetic gingiva to look darn good. And that might be using the native bone or a graft to be able to place implants and then put a prosthesis in that has prosthetic gingiva. And there's a saying that I like. There's not a lot, if you're going to use a little pink, what's the difference between using a lot of pink and a little pink?
That's right.
So,
right.
Yeah.
That's right.
So I kind of favor that again, and that falls into the more minimally invasive approach. Some patients will accept that and say, okay, I understand as long as it fulfills the aesthetics, they'll accept artificial gingiva. Other patients more invested in getting something back like their normal dentition, and as long as you discuss those limitations. Now, in the posterior aspects of the mouth, there I don't find the discussion is as challenging. If it's a short implant case versus vertical, I use my clinical judgment to say, yeah, you're a good candidate to do a short implant here. I can develop an occlusal scheme where I'm not too worried that you're going to overload this. We can have enough native bone to work with. I got enough bone above the canal that I can place an implant here or in the maxilla. Maybe I have to do a sinus augmentation, but a lot of times we can do more minimally invasive sinus. Instead of doing a lateral window, I might be able to do, internal lift. So those come into play. And then looking at implant design, if I am going to use a short implant in the maxilla, I favor a more aggressive thread, better primary stability. And then when the implant does heal, maybe more surface area around that implant. So I don't want to get into companies and brands and stuff like that.
No, that's okay. We don't. That's okay. But do you feel that as we kind of come full circle back to where we started talking about short implants and what they've done, do you think they've started to or have eliminated a lot of autogenous block grafting? Do you feel like that's maybe been a major change?
Yeah, I do much less block grafting for vertical augmentation because it's not that morbidity is high, because if you use for instance, the mandibular ramus, that has very low incidence of, FUD, Quarry's work, my work. I've never had a paresthesia from harvesting a ramus block. And using the split block concept is great for horizontal and vertical augmentation. But if I want to, I think a simpler approach is the PTFE, titanium reinforced particulate bone harvest. I think that's maybe takes a little less time surgically. However, I will say dense PTFE membranes, the complication with infections and incision line open, I just think across the board, I see more problems with that than I do autogenous blocks. But I have trended away from blocks from some types of cases. Or if I do harvest a block, a popular technique that I use a lot is, let's say someone has a horizontal defect in missing central incisor. I simply go apical, take a trephine burr, harvest the block from the recipient site, move that in place, put a screw in it, put some particulate autograft, cover it with membrane, and
just a segmental osteotomy.
exactly.
it's just
idea.
well, it's a nice side. Autogenous bone heals faster, so that block graft 4 months later, I'm going back to place an implant. Whereas if I do particulate bone with the barrier membrane, probably giving it 6-7 months, a little bit longer to heal. So anyway, and tuberosity is another donor site that can be useful. Posterior mandible, using bone scrapers, that has very low morbidity. So there's a lot of different areas that we can harvest bone. Howie Gluckman uses the palate, has very low morbidity with that, and has good success. So I think there's ways that we can still utilize autograft or utilize block concepts, but decrease the morbidity.
Yeah, and not having to get as much bone. Like you say, with having a shorter implant availability, you're not having to push it as far, which it sounds like is a massive change in the last 10 years in the way you think about it.
So as we kind of conclude, I think I would love to hear what you feel like in your career has been the one tool or technique or piece of knowledge I can't live without on a day-to-day basis in treating my patients.
Well, it's been digital planning, prosthetic-driven bone augmentation. I mean, that's been invaluable because instead of going into this and saying, well, I'm just going to try and augment this ridge. Now I'm going in with a lot more knowledge, a lot more information, and saying, this is what I need to achieve, and this is how I can do that with whatever technique that I want to utilize. In the text, there's Italian Dr. Alessandro Cucci. He's makes a printed model of the augmentation. He then makes a carrier, prints a carrier for the membrane. So he can trim the membrane using this, and then he's got this carrier that he can fill the graft, bring that to the mouth. So instead of
hold it in place.
Instead of, you're trying to pack in the mouth, he's got it all done here. And especially if you use something like platelet-rich fibrin, it congeals that graft, and then you're taking this carrier and putting that. So using digital technology and things like this are going to continue. And then some of the cases where you can, Zastro's using digital technology where he's making templates for harvesting the graft, making templates for, how am I going to cut this and how am I going to rebuild it? So you're kind of like an architect building this ridge augmentation before you even go in and see the patient.
That's pretty amazing. I think the thing that I love is that when you hear a surgeon say that the restorative plan is the most important part of my practice now because it controls and helps drive the surgery even more. I mean, that's what it's been like for the entire time we've been placing implants for the most part. It's
Yeah.
thinking that what are we giving to the patient? We're giving them teeth.
Right. Right.
How are we going to alter our surgical protocol with the least invasive techniques?
Yeah.
Right.
And
now this can be done in almost in office in terms of the planning if
Correct.
you want.
Yeah.
And back in the day where it was, you would go
Oh,
to
man.
Materialize, and you say, I want you to give me a jaw here. I want
Yeah.
you to give me a 3D, and you could get that, but it would
Yeah.
take so much time and
Yeah.
cost.
Money.
And now we can potentially, print a guide
Yeah.
that we can use for bone harvesting, potentially for member. I mean, that's obviously changing at a incredibly rapid
Yeah.
pace. So I think this has given us a lot to think about. Thanks very much for spending some time hanging out with us today.
That's great.
We really appreciate
Good
that.
questions.
And-
super excited about the new book too from
Yes.
Quintessence.
Yeah, definitely go check it out. If once again, another reason you should be here at the AO is to be able to go over to Quintessence and see what's come out, because that's a place we always keep going back to, because there's no replacement, we believe, for textbooks, for journals. We've got to be reading, we've got to be cracking those open and seeing what we need. So if you're listening to this, obviously, hopefully you've learned some things. You've learned where we need to go to learn more. And Wes, I know that I'm going to enjoy picking that book up and just kind of learning more about what we can be asking of our specialists, of our surgeon, to say, hey, this is have you reading this? What are you reading?
Yeah.
And what's messing with you? Because that's definitely messing with
It
us.
could be another Dental Guys book club, John. Right.
It's about time.
It's about time.
Well, one of my favorite chapters too is these custom meshes. It's a game changer.
Yeah.
I mean, instead of trying to cut a membrane and they fit so well. 2 screws.
That's
Amazing.
it.
Yep.
Yeah. Love it. I love it. So head over to Quintessence right now. They're friends of the Dental Guys podcast, and we've known those guys over there. They are the highest level in production, we believe, in dental implant education from a standpoint. They are the publisher of iJomi and partners with the Academy of Osseointegration. So I really appreciate Dr. Misch coming on. He's a longtime well, I want to say he's a dental giant, he and his family both. And I appreciate all that he's done for our field of dentistry and continue to push the boundaries. It's about going beyond the boundaries at the Academy of Osseointegration 2024 meeting. So for Dr. Misch, for John, I'm Wes, and we are the Dental Guys.